All right, so we'll get started. It's at the top of the hour. So hello everybody, welcome to another February rendition of the Ribinar. Tonight we have with us a group from the Hartford Hospital. Dr. Phillip Kim serves as a dual role at Hartford Healthcare as the trauma and acute care surgeon at Hartford Hospital and as an innovation leader for the healthcare system. He currently serves as research director for the Division of Acute Care Surgery with a focus on integrating innovation and emerging technologies into trauma and acute care surgery and research. The work being presented today was supported by the Hartford Healthcare Summer Student Pre-Med and Research Program. This project was led by pre-medical student Jared Maidman in close collaboration with multidisciplinary clinical partners and a technical advisor whose collective efforts are instrumental to its success. So I'll turn it over to you for a practical guide for low-cost 3D printing of chest wall anatomy for rib fracture visualization. Take it away.
Thank you so much for the kind introduction. Hi, everyone. I'm Phillip Kim. Joined with me today here is Jared, our first author, and also Ashish Bakshi, who's also our technical advisor. Just wanted to go over a process that our research team figured out to basically be able to print really from day before surgery, be able to print a 3D model that's a miniature model of the patient to go from the CT scan all the way to a model without needing any institutional resources. All you need is a computer and a budget printer. And then a budget printer is about $219, the cheapest one we used. So it's quite approachable budget-wise. And we did this all with a $0 research budget. So hopefully it means that it's very approachable. First of all, we have no disclosures to share. So just to start us off, our patient was a 30-year-old healthy male who sustained a MVC. He was found to have pretty bad right-sided 1 through 12. All the ribs were broken on the right with flail chest component with posterior and anterior segments, fractures that were there. He had a hemopneumothorax, so required a tube thoracostomy. And otherwise, we have a SSRF group here at Hartford Hospital, so we evaluated his imaging, his clinical status, and deemed him appropriate for SSRF. And we try to get it done as soon as we can. So I'm sure like most of you, at least when we were traditionally going about doing SSRF, we traditionally just start with the CT scan. And here at Hartford Hospital, we're lucky that we have that, radiology technicians who can make 3D models for us, where they can include the scapula, not include the scapula, isolate one side or not. But it's still mostly limited to, looking at a 3D model on a 2D screen and swirling it around and trying to imagine it in your head. And then sometimes if you don't have the 3D model in time, you're looking at the axial, coronal, and sagittal images like we're all trained to do. But our research team thought is that with the advent of these very cheap $200 budget 3D printers, perhaps we could just 3D print the patient ribs, just like you're hitting print on a Word document, just go hopefully print the CT scan, and then we can have a nice model of the bones, a smaller model of the bones to be able to look at, so that we don't have to spend the time trying to swirl in our minds, and especially during surgery, try to go back to the screen. That's a flat screen by nature. And when we talk to patients, I don't have a model that I use. I just said your ribs are 1 through 12 are broken. They're pretty badly broken. You're going to do badly. We think this will help you, but this is the surgery. And we never really had a physical model to go over patient education. So I thought that was a sort of a problem statement that we started with. The solution that we came up with was a process that basically can convert the CT images, like I mentioned, to a 3D model. And I have an old one right here. I give all my models to our patients after we operate. So I don't have, this is the only one I actually have right now. But you can see it's a small model that's about palm size. You can make it as small as you want, but I generally make it around this size so you can at least tell what it looks like. That scale down, it produces a high fidelity miniature model of the patient's anatomy with low cost. The filament for this is about $4.50 each time you print, so plus whatever electricity costs, but that's not too much. Can be utilized for preoperative patient education, surgical planning, and intraoperative surgical guide. And as a bonus feature, you can actually put numbers on the ribs, because I don't know about you, but when I operate, I always find it hard to identify which rib I'm on for a while, unless it's very easy from the beginning. And this model can really help you know which rib you're on when you're operating. So. Without further ado, if you can take anyway from this webinar, please, there's a link to the video tutorial that Jared here made. It's 10 minutes long. It's obviously sped up. The actual process takes about 30 minutes, but it goes from beginning to end of how to do this. There's a QR code for you and a link there. And just quickly show you, this will be Jared talking, and it kind of goes over the entire process step by step. So I think it's a lot easier to follow a video than a paper. So we made that in conjunction with the paper. So and it's on the first page of our paper as well. The link is there, so you can use it. So, publicly available.
Hello, everyone.
All right, just to go over the process real quick, it basically involves first downloading the CT images, the DICOM files that many of you may aware of from getting CDs of patients. That includes the images of the CT scan of the chest. You can use a free software called Invasilius. That's a open source software made from Brazil that then converts it into the density that you want. We can select bones or the density of the bones. If it's osteoporosis, we increase that range. And then you get this raw file that is very dirty with EKG wires, the CT couch, both sides, the heart if there's contrast. So then you can use a mesh mixer program, kind of like Photoshop, to clean out what you need to clean out. You clean out, get rid of the wires, get rid of the other side of the chest. And then that gets you to a model that you're pretty happy with that you can send to your printer software, which then converts it to a G code to be able to print it in time. And the printing takes about, anywhere from 10 to 16 hours. If you really need it rushed overnight, like it's the day before, you got to get this done. I've once started at 6 p.m. the day before surgery on 7:30 the next day. You can get this started, printed within 9 to 10 hours if you print smaller. So the size dictates the amount of time. Just to give you quick screenshots, this is what Invasius looks like once you import the DICOM images. This is how you select the density Hounsfield units to kind of go over. The green is what it will select from the CT image and create a model. So on the bottom right, you can see that it has all the EKG wires, the ribs, the sternum, everything that you want, plus a lot of extra things. And then you take it to a mesh mixer where you can clean it up to make it a much, much more cleaner model that you can actually discern some information from, isolate to the chest, the sidedness of the chest that you want, and then print all 12 ribs out, including, I like to include the scapula and the clavicle because especially for those posterior lateral fractures, it's really relevant. So I keep those in view to kind of keep everything oriented together. Another bonus feature that Jared here figured out is that you can put numbers on them and annotate the model because you're not just limited to what's in front of you, but you can actually edit it as if you were preparing for surgery. So you can actually write all the numbers on the ribs. You can even write text on the ribs if you wanted to write some, fix this with a plate, or, if you wanted to actually keep notes for yourself, you could do that too. But for now, we just stick with numbers. So. And then after that, you send it to the printer. You let it, you scale it down. The average model that I'm printing with the cheapest, smallest printer is 5% scale. So this is 5% of a real human being scale. Although there are printers, commercial printers out there where you can print life size. And I know there are services that cost thousands of dollars that you can do this out there. But my whole point was why pay thousands when you can do this for $5. So you can print it for a small scale. And I find that even when it's a smaller scale, it has all the details in such high fidelity that all you have to do is just zoom in and look closer and you can tell all the fractional morphologies pretty well. One thing you do have to add is supports because of the fusion deposition modeling technology that the 3D printers use. You can't print in thin air. So you have to have trees and supports to be able to print up to a rib. So those trees will be in the way of looking at the ribs from underneath the model, not from the top of the model. And some tree supports we can remove, but if you remove all of them, the ribs start falling apart when they're broken. So you do have to be careful which supports you take off. And yeah, that's then you send it to your printer. That's a picture on the left is from halfway, third way through the printer. That's how it looks like with all the trees growing in. You see the spine's already been printed and the ribs, the posterior and anterior ribs are being printed. And then on the right side is a completely printed model. And then there you can get rid of all the lateral tree supports, ones that are at least not holding the fracture fragments. And then I would keep the ones holding the fragments because otherwise the fragments will fall apart because there's nothing attaching the two ribs together. So. So in conclusion, our patient was taken to the OR with Dr. Rowe here. I think she's on the call. We use the model to cut down to fractures. We use the unique morphology, fractional morphology to identify which ribs are which, especially if you have a chest tube in the CAT scan. If you're lucky that you don't always have it, but if you do, that immediately gives you a 0.0 landmark of where the chest tube is relative to the rest of the chest. So that's really helpful if you have a model and can compare that one-to-one. And then we rib plated ribs 5 through 9 using Zimmer blue plates at the time. And then he did really well and recently communicated with him. This is about a year ago, but he communicated recently with me that he's really grateful for the surgery and back on his feet. So that's all I had prepared. Did anyone have any questions? I'm not sure if I'm moderating, but I see Joe's hand is up. Go for it. Ashish and Jared, do you guys have anything else you guys want to add?
Well, happy to answer any questions anyone might have.
Yeah,
And I'll go ahead, Joe.
yeah, Doug. So really cool stuff, but where do you think it's going? Where do you want to go with it? How about that?
Yeah, so this is just the first step of this journey. I didn't, and right now our research team is thinking about the next steps, and we have a bunch of ideas. One of the ideas is that we actually were able to get the 3D models of the plates themselves, like the Zimmer plates, obviously confidentially, so that you can have them and scale them down at the same size, so you can potentially prepare what plates you would use ahead of time in the same size ratio to the ribs. So that would be one step where you save some time preparing for surgery ahead of time. So you don't have to make those game time decisions as much. Obviously, there's a chance that fractures do change over time from the CT, but for the most part, they do stay, relatively consistent. So that's the one thought. Another thought is be able to automate this process for surgeons so that, truly, if I can make this a print to printer, just a button for you to print, I think that would be amazing. So that's one of my hopefully goals of mine. I'm collaborating with some engineers to do how to do that. So, because I think that'd be a huge
Yeah,
service
I
for the
think
community.
that
Yeah.
that's one of the, it's an idea that a lot of people have kind of proposed is this idea that to kind of prepare plates and things that are customized for the patient, but you have to remodel it in the reduced form, right? Because you wouldn't plate the fractures as they stand, and so I think that's what people are thinking about is like, okay, here's the fracture pattern. What does it look like when we reduce the fractures, and then how do we prepare plates for that? But I think that's going to be the interesting or the challenge in the future.
Yeah, that's a great thought. And that's certainly technically feasible because there are 3D printed filaments out there that are flexible. So you can actually print certain segments flexibly and some segments rigidly. So you can have the rib model actually be able to bend and move. And that could be an amazing next step to be able to, have a more high fidelity reduction of ribs. So.
One thing that I'm seeing here in the chat is a comment about any legal issues giving your patients the 3D copies.
No, we submitted this to IRB as a QI project, and just like we 3D, paper print 3 CT images. I before this I was printing 3D pictures of our patients in the OR, like putting it on the monitors. That was my way of operating. Right now, because it is their property, obviously it is HIPAA. This patient has agreed to share all of his models and be published for the community with written consent. But yeah, I would not share it publicly ever, and I have not shared any of this except for this patient's model publicly. But I think giving it to the patient himself, it's his image, it's his print, so I have not encountered any issues yet. But I'll let you know if I do. Yeah.
Just a few comments. I've done about probably a dozen 3D prints that are life size. And got our radiology techs to do that. I found it most useful for the non-union cases, and I know that Tom White has done. I think he was one of the first that I saw walking around the summit with a 3D model in his pocket, trying to tout for ideas as to how to manage a particularly challenging patient with if I remember, a first rib non-union that was quite lateral. I found it very useful for some of those, also for some sternotomy cases, chronic non-united sternotomies, where again I've just been trying to work out in advance what plate system to use. And I just have from the suppliers a bunch of non-sterile plates that I can, of certain types that I can use to just to play around with 3D prints in that. The non-union cases are good because it kind of helps you visualize density quite nicely so that you can determine when you might need to use a bone graft. And I think that sort of thing is quite useful in advance. The other thing I find difficult with I can do my own 3D reconstructions in seconds, but it's actually quite difficult once you have a 3D radiologic model on the PACS system to actually then apply measurements to it. For some reason, it doesn't allow us to use the 3D recons to drop points and measure between them. You have to do that in planar images, which is a bit of a pain. So again, when I've had a complex non-union to look at gaps, look at where fractures lie, just think about what plates are, I found that invaluable. If you talk to your CMF guys, they use 3D prints a lot. And I think some people have toyed with the idea of pre-bending plates for extra thoracic fixation. I don't know that anybody's actually done that and then re-sterilize the plates for use in the OR, but that's something that could be a time saver if you fancy doing that. So I think there's lots of potential. I'm not so sure about the small models. That seems, I get the idea that it really cuts down the print time and the cost to make it very little, and is an easier memento to give the patient a key ring of their chest. But yeah, I mean, I think it's something that's really useful.
Thank you for sharing, and I agree with all your thoughts. I think I found it actually more surprising. I was surprised how useful the patients found it when I use it for preoperative education, because then they can put their fingers along the fractures and feel them physically and feel where it's broken and see where it's broken to kind of understand why we're doing our surgery. And I like seeing that satisfaction a lot. Obviously, I haven't quantified this or any research yet, but personally, that's been sort of rewarding to be able to have a more deeper conversation, at least show them what we're trying to do. So, and definitely, I put it on a Mayo stand in the OR. Obviously, it's not sterile, but I put it on a Mayo stand next to me, and I just go over there and look at it time to time to make sure I'm in the right spot and reorient myself if I'm off plane or off where I think I should be. So I found it useful as a guide as well. But obviously, life size would be better. But the problem with life size is then where are you going to put it? It's so big. So, and it does take a long time to print. And then definitely the other limitation of our model, even this paper, it takes 30 minutes about prep time if you do it a few times, and about, overnight printing takes anywhere from 10 to 16 hours depending on the size. But the plus side of that 30 minutes, about half of it is you're looking at the model and manipulating it and cleaning it. So you do, as a surgeon, I think, spend that time with the model so that you have some familiarity of how the fractures look like as you're rotating it, cleaning it, spinning it. So I do think it's not all wasted time for those time spent cleaning the model and printing it. But obviously, if you can automate it and make it push, click, plug and play for you, then that will be awesome. So.
Hey, this is Rajiv from Hobart, Australia. I was just wondering whether there are plans to make 3D models for ribs in patients who got completely shattered ribs and you want to just replace them. And if there is, what material would be using?
I'm not an expert on this, but I think there was a journal club on this recently of bioabsorbable prints, if I remember correctly. But I'm not. I don't know if someone else could speak to that, but
I can help answer that. I mean, it's certainly possible for companies to 3D print titanium custom implants, and that's done a bunch of times. Again, it's relatively unusual for us to do that in the chest. There's the opportunities for things like sternal replacement for sternectomy for cancer is one thing that has been done and described. I've toyed with it for some sternotomy reconstructions where there's been a huge amount of bone loss, and I was not convinced we could get enough bone graft in. But I mean, certainly in the acute setting, I don't see that as a role. But I mean, it's certainly possible to get a company to have a rapid turnaround within 10 days or so for titanium 3D printing. I see some honored industry guests in the participants who may be able to talk to that more. But I mean, basically, most of the companies, as far as I know, have that facility mainly from their CMF teams. But the idea of printing absorbables as well is something that is interesting, but I don't know that has been done in the sort of thoracic skeleton world.
Thanks for that, John. Currently, I'm still using the Strekos gold bars in case I have to just do away with a totally shattered rib. It's been reasonably helpful. Thanks.
Also have in the chat here that Dr. Zakaluzny did a single non-union rib printed with the rib and pre-shaped the plate, real-time saver, one case experience. And that was the question I had for you is how much time did this save you, or how much time do you think it saved you?
I'm sorry, are you asking me or Dr. Sakaluni?
Oh, I'm sorry, I was asking the group.
Oh yeah, sorry. Yeah. You know, the time savings, I think it's definitely depends on the patient. If you have a really skinny patient where you can feel all the rib fractures, I don't think that the model adds that much more benefit other than the education component of it. But I do think if you have a bigger patient or patients with complex rib fracture morphologies, I think it really does help with not only planning, like by single planning, but also a lot of times we're doing these with our partners and, you know, kind of bouncing ideas off each other. So if you have a model in hand in the morning, right, you know, 7:20 in the morning with the surgeon and we're discussing our approach, then I think it really does help kind of expedite that discussion faster instead of both carrying onto a seat, you know, a 3D model and trying to explain things instead of just picking it up in your hand and being like, this one, let's do this, this one, let's do this, and kind of keep track of what our plan was.
I
Go ahead, Dr. Edwards.
Sorry, yeah, I have an idea that that is slightly left field for this, but for external thoracic plate formation, there's no reason that a clever industry partner couldn't take a CT scan. Say you want to fix the left sixth rib, you take an image of the right sixth rib, flip it, invert it, so you know the shape, and that means that you can then create a plate. You know where you want to put the plate, and you have not a milling system, a plate bender, an automated plate bender, where you feed a plate into the top of a machine. You press a button, and out of the bottom, like a slot machine, out comes a plate that is pre-shaped to your sixth rib that is exactly right, that takes human hand away from it. I guess it would just take a few little rollers to enable that to happen. So there we go, Tom Albertson, come up with a milling machine. The problem is it costs a huge amount of money, but I quite like the idea of being able to take a CT scan, plan from the opposite side and invert it, work out which plates you need, and then you kind of press a button and out at the bottom come a number of plates, like a machine at the fun fair, and you just sterilize those, take them to the OR, and you don't have to do any intraoperative plate contouring at all. That's a dream. Whether that'll ever happen, I've no idea, but it sounds like an interesting thing to me.
Dr. Edwards, interesting that you
It's
said
gonna
that.
happen, John.
So the case I did, the single case, the guy had a non-union and he actually had a segment of rib that was missing. So I got a bone graft from the iliac wing. My orthopedic surgeon helped me. And I had someone take the images similar to what Dr. Kim was showing And they initially kind of reconstructed the rib, but then they did exactly as you said, Dr. Edwards. They took the other rib, mirror imaged it, found that it was a good fit, and they printed that rib for me, that single rib, and I shaped the plate. And you asked how much time it saved. It was because of the gap and then the quality of the bone. That was I wanted to go. I wanted to make sure I secured the plate significantly anterior. So it was a long plate, and I actually did two incisions. And so trying to say as minimally invasive as possible and get a really long plate in there and shaping that, it saved me a significant amount of time in the operating room. I probably spent an extra 10 or 15 minutes like really making it perfect since I was sitting at a table. But I'd say it saved me. It's easier also. You can manipulate it on the table to the rib compared to in the chest. So I'd say it saved me at least 15 to 20 minutes because of how awkward it would have been to this long plate across two incisions in an area where there was a gap of rib that I was putting a piece of graft in.
Yeah, John, I was going to say, I don't think your idea is far-fetched at all. And it's really only a matter of time. You have peak plates that are ripe for 3D printing. And so I think you're absolutely right. I as far as like, filling in gaps and things like that, you had one case where I use cadaveric fibula graft and filled in a gap with that. It's kind of a perfect size. You can cut it down. You can to look basically like a rib, at least a rib segment, and it works very well.
Yeah, I really like the idea as well. And just to be clear, our methodology, you could technically isolate it to just one rib and print it life size. So you can actually just focus on three ribs and make it life size if you have a big enough printer. And you can print other bones as well, or heart or brain. Or the idea came because someone had printed their MRI of their brain from home. And I was like, if Joe Schmuck can print his brain at home, I should probably figure out how to print someone's ribs. Someone has a hand up, please. Yeah, you can go ahead.
Yeah, thanks for the presentation, Phillip Kim. I wanted to add to the discussion that in our hospital, in the EMC, we are in the CMF guys, as John was talking about, they already use pre-planned like removing of the mandibula, and they pre-cut the fibula to replace the mandibula in case of cancer there. And they 3D plan the cutting of the fibula, and they 3D print the plates that go on there. And I think such a system could be useful in this case as well. Like when you have big gaps in ribs, maybe you don't want to harvest the fibula, but you could use indeed bones from other places indeed. Yeah. So if anyone's interested, maybe I can connect you to how they do it here. Yeah, just throwing that out there.
Yeah, thank you for sharing. I definitely feel like some of our subspecialists use the technology way more in commercial applications. So hopefully that means eventually our commercial partners will create custom plates for us as well.
Dr. Kim, way off topic. I saw that you had two chest tubes that you listed in your patient. Is that your common practice, and if so, why? And tell me more about that.
Yeah, I think I was trained old school, and that was how I was trained. Always have an apical 28 and a basilar 28, and I know That's not the popular thing anymore. So I could probably move to one chest tube. I'm not ready for the silicone chest tube just yet, but the pleural cavity. But
Oh, come to the dark side.
exactly,
It's
yeah.
nice and
Maybe I'll come
warm.
to the dark side. Yeah, but I did figure someone was going to say something about that. So
Well, we're gonna present a paper or have a presentation at CWIS looking at chest tubes. We were using a Blake drain, a 24 French Blake drain, and my other team was using a 14 French pigtail, and we had similar outcomes. I switched to the 14 French pigtail. Actually, my outcomes improved after that, as far as reintervention. So pleural reintervention, like, do I need to, if I take the chest tube out, do I have to put something back in? Do I have to do a thoracentesis? Do I have to do something else? And so it works. It works. So
thank you.
hopefully
Yeah,
that that presentation will help this coming CWIS.
thank you. Yeah, it's fun because I'm trying to be innovative in some ways, but I'm also very old school in how I practice. So I probably should merge.
You're too young to be old school. Come on.
Trained by people who are old school, I guess. Yeah. Anyone have any other questions? We really appreciate everyone's questions and ideas. And I really like the idea of using the contralateral rib because I'm hoping that most patients have symmetrical ribs from left to right, unless they've had a prior injury before, to have that symmetrical nature so that you can just mirror it. I think that's a great idea for missing pieces. So, yep, go ahead. Yeah.
I was wondering, do you plan on integrating this into standard care? And if so, how?
Yeah, I think, I mean, for me and I print it for some of my partners if they ask for it, but for me, I've been doing it for every case and giving it to the patients, and I've enjoying that as just making my part of my care process. But yeah, I think to make this more of a standard care, I think we have to demonstrate the benefits, and really, like, data speaks volumes more than just one story. So I do think it'd be great to capture some of the benefits. And also to make this easier, because this is just the rough form of trying to do it in 30 minutes at home, sort of, for lack of a better word. But, to make this more really sort of streamlined would be awesome, because then if it costs only 5-10 minutes of your time, I think more people will be willing to be able to do this easily. So, because, I was sort of willing to take that risk of spending a whole weekend trying to figure this out. And, it did take a whole weekend. So, yeah.
Dr. Kim, I was just wondering, I might have missed that. How long does it take for you to print this 3D model? And would that actually delay the patient being taken to surgery?
Yeah, so if you're in a rush, like I've actually received the notice that I'm going to operate on someone the next day at 7:30 a.m., 6 p.m. the night before, you can still make it happen. The preparation takes about 30 minutes if you've been doing it. And the first time you're doing this, it may take you an hour. But once you get used to the steps, it's faster. And then the print time, you can edit it based on the size. If you make, my cheapest printer only prints 180 millimeters by 180 millimeter by 180 millimeter size bed. So that's your 3D restrictions. But if you make it even smaller, you can print it in 9-10 hours. So that's enough to print overnight. So as long as it doesn't fail, 3D printers are not 100% perfect, but usually I've been lucky in that they all worked out by the 5 a.m. the next day, so that I can take it off the print bed when I wake up in the morning and go to the OR with it. So, but ideally, if you have at least 2 days notice, it's safer, because then you can print it the day before, sort of bring it to the patient a day before, do that preoperative education maybe ahead of time. And that's sort of my ideal scenario. So, but what's great is that unlike commercial applications, you really can turn these out within 12 hours. So, which I don't think any commercial application, at least today, correct me if I'm wrong, is able to do that for you. So.